Okay, we'll move on to pancreas now. And you're going to be doing pancreas again when you do the digestive system. So a little bit of what I'll show you now is going to be repetitive. So the pancreas is both an endocrine and an exocrine organ. The endocrine part is in an area known as the islets of Langerhans, so this area, which is predominant in the tail of the pancreas. So the tail of the pancreas contains most of the islets. So if you look at the pancreas, so this here is showing you a picture of the pancreas, and look at all the organs it is related to. Here is the duodenum, which is part of the small intestine. So it looks like a C, somewhat like a C, like that. So it lies in the C of the duodenum, and it goes all the way till the spleen. So it lies right across the abdominal cavity. And this pancreas is divided into a head, and then there's a, kind of a narrow area here which we can call the neck. So this part here is the neck. Then this main portion is the body, and this is the tail of the pancreas, which is very close to the spleen. So that's where majority of the islets of Langerhans are situated. And this relationship with the spleen is rather important, because when you do, if the spleen ruptures because of any problem and you've got to remove the spleen, you have to be really careful that you kind of push the tail of the pancreas aside and then remove the spleen, because if in a hurry with all the blood over there, if you kind of ligate in this area and catch the tail of the pancreas, then what will happen is that, first of all, you kind of make the patient diabetic, because that patient would not be able to produce insulin. And also all the digestive enzymes would keep secreting out, and the whole peritoneal cavity could kind of undergo autodigestion. Okay, so that relationship is rather important. Now, the two main cells that we are concerned with in the pancreas are called alpha and beta cells. The alpha cells produce glucagon. The beta cells produce insulin. Both of them have to do with glucose metabolism, but they are antagonistic to one another. Very similar to when we did parathormone and calcitonin. If you remember, parathormone raised serum calcium, calcitonin depressed serum calcium. So here, glucagon and insulin have the opposite effect. Insulin lowers the blood glucose level. So insulin lowers blood glucose. Glucagon does exactly the opposite. So it raises blood glucose. So you can see how they're antagonistic to one another. Now, because diabetes is something that, we talk about every day, and the incidence seems to be on the rise because of obesity and other things. So let's kind of look at these two hormones in a little bit more detail. So here is a normal balance. Your blood glucose levels should be about 90 milligrams per 100 ml. 90 milligrams per 100 ml of blood, could go up to 100 or 120, but no more than that. But let's say that there is an increase in blood glucose level. So there's an imbalance. Your blood glucose level increases. The blood's flowing through the pancreas. In the pancreas, the receptors sense that. It secretes insulin. And what insulin does is it takes the glucose from the blood and pushes it into the cell. Insulin is required to push the glucose inside the cell. So the uptake by the cell increases. Any extra glucose which is present is sent to the liver, where it is converted. Glucose is a simple sugar. It is converted into a complex sugar which is known as glycogen, and that's how glycogen is stored in our bodies, as a complex sugar. Starch is another complex sugar, but we don't store starch, we store glycogen. And hence, because it's pushed into the tissues, glucose has been made into glycogen and taken up by the liver. So now your glucose levels fall. And, it comes back to normal. Let's say if there is an imbalance. And an imbalance is, let's say someone has not eaten for many days. This situation would be, let's say you've eaten, immediately had a meal, your blood sugar will rise, and that's when glucose levels rise, and that's when insulin is produced. But let's say you haven't eaten for a very long time, your body still needs energy. So your blood glucose levels fall. This is picked up by the pancreas, by the alpha cells of the pancreas, which begin to secrete glucagon. And what they do is the stored glycogen in the liver, they break that down into glucose, and then that is pushed into the bloodstream and your glucose levels rise. So can you see how they do exactly the opposite, okay? So here let's look at it. So the functions of insulin, it lowers blood glucose by increasing the uptake. So it allows, there are certain sort of channels which will open up, and I'll show you a video on that, which allows glucose to be taken in by the cells and then utilized by the cells. If insulin is not there, you may have as much glucose as you want outside, but it cannot get into the cells, which is what happens in diabetes. Because its action is to lower blood glucose level, it prevents breakdown of glycogen. Instead, it causes conversion of any extra glucose that you may have. It converts it into glycogen. Okay, so it prevents breakdown, but converts it into glycogen. It prevents what is called gluconeogenesis. Remember, I went over this term last time. That means glucose from new sources or non-carbohydrate sources. So gluconeogenesis is from fats and proteins. And if you remember, cortisol did that. It caused breakdown of fat to produce glucose, breakdown of protein to produce glucose. This does exactly the opposite. It prevents gluconeogenesis because you don't want the glucose to it doesn't want the blood glucose to rise. So by preventing gluconeogenesis, it's going to prevent blood glucose from rising, right? So since it prevents breakdown of fats and proteins, what it does is, on the other hand, it causes fat and protein synthesis. So let's say you've eaten a lot of food. Some of it is, food is broken down into, or your carbohydrate is broken down into glucose, which is absorbed by the bloodstream. Your body utilizes some of it to make ATP and you use it. The extra is stored in the liver into glycogen. It's made into glycogen and stored there. But let's say you still have some more glucose. So then what happens is, or you have other, like lipids and proteins. So what it does is it actually helps to convert the glucose into fat and helps with protein synthesis. So it prevents their breakdown. Instead, it helps to cause synthesis of fat and proteins. Okay? So it does everything in its capability to reduce blood glucose levels and prevent them from rising. Glucagon does exactly the opposite. So you can see it raises blood glucose levels. It will do this by breaking down glycogen in the liver. So that process is known as glycogenolysis. The word lysis means to break down. So it causes glycogen to be broken down. And it causes fat and protein to break down and produce glucose. So that is called gluconeogenesis. So you can see how it's going to raise blood glucose levels. So let's take a look at how insulin actually helps the cells to take in or utilize this glucose. So some of it may not necessarily pertain to your class, but yeah, it's still a good video to be looking at.
Hi, this is Mark from the MSOE Center for Biomolecular Modeling. The following animation will molecular mechanism whereby insulin triggers the uptake of glucose from your bloodstream. Soon after a meal, the digestion begins to break down what you have eaten. The carbohydrates in this food are broken down into a simple sugar called glucose. As this glucose is absorbed from your digestive system into your bloodstream, your blood sugar levels. Your circulatory system then carries glucose to muscle cells throughout your body, where it is used to generate. Here's the important part. In order to get glucose that's now in your bloodstream into your muscle cells, you need to have insulin present to trigger that uptake of that. Insulin is a small hormone produced by your pancreas. The concentration of glucose in your bloodstream rises. Your pancreas senses this increase and is stimulated to release insulin into the bloodstream. Newly released insulin plays a key role in regulating the concentration of glucose in your blood, a process known as glucose homeostasis. The insulin is released into the extracellular domain of receptor proteins found on the surface and fat cells. This binding triggers the autophosphorylation of the intracellular domains, which, in turn, phosphorylate a specific signaling protein. This protein then phosphorylates other downhill signaling proteins, leading to an amplification of the signal at each step. This overall signaling process is known as a signal transduction cascade. One important consequence of signal cascade is the movement of glucose transport proteins, called GLUs, towards the cell surface. As these vesicles fuse with GLUs present on the surface of the cells increase, allowing the glucose to enter the cell. As a result, the glucose concentration in the bloodstream decreases. The glucose is now inside the cell, where it can be metabolized to generate the energy in the form of ATP that is needed in all of your cells. And that is how insulin helps the sugar you eat turn into the muscle that you use.
I mean, for transduce, but you can see that if it is not present, if insulin is not, you can see that glucose will not enter inside the cell. So you may have as much as you want outside, but you need the presence of insulin to allow it to enter into the cell. So the clinical conditions which are associated with malfunction is diabetes mellitus. So remember, we talked of diabetes insipidus, which was when you had lack of ADH. That was also called diabetes, but it was called insipidus because there the urine was insipid. It wasn't sweet. This is called mellitus because the urine has glucose in it and so it's sweet. So there are two types of diabetes mellitus. Type 1 is thought to be an autoimmune disease where the beta cells are destroyed, so no insulin is being produced, and hence you have to metabolize other substances in order to produce, to give energy. So fats are mobilized, and when fats are mobilized to produce ATP, the end result is usually something known as ketone bodies. These are also known as keto acids. So this leads to a lot of other problems. So the patient ends up in something known as acidosis because it's an acid. So it liberates hydrogen ions. So the pH level falls and it ends up with ketoacidosis. Type 2 diabetes, on the other hand, is, and type 1 diabetes used to also be known as juvenile diabetes, or early onset diabetes is what it used to be called, and this one used to be called adult diabetes or late onset diabetes. So in type 2 diabetes, the problem is that insulin is produced, but the amount is not enough. So there is deficient insulin production, or the effect, insulin is not able to act because the tissues are resistant to it. And usually type 2 diabetes is seen in obese individuals, and it's felt that the obese individuals, their bodies produce something known as resistin, and that actually has an anti-insulin like effect. So that's why their bodies are resistant to the effects of insulin. And normally all of us have in our fat tissue, we have something known as leptin. We have a hormone called leptin. And leptin is very important because it depresses your appetite and increases energy expenditure. But they feel that in fat people, for some reason, this leptin actions are not heard by the body. So with the result, there is that decrease in appetite and, increased expenditure of energy doesn't occur. So, they have two things going for them. One is they are resistant to insulin. On the other hand, they have this other thing which is normally present in the body, but the body is not reacting to it properly. Now, in any diabetes, not only type 2, you have three kind of very typical symptoms. These are known as polyuria, polydipsia, and polyphagia. Poly means too much. Polyuria meaning too much urination. So there is too much urination. Polydipsia is too much thirst. And polyphagia is increase in appetite or too much of an appetite. And this can actually be explained why this happens. So if you think of it, what happens is because now here in these people, the blood glucose levels are high. So they eat their food, the blood glucose levels go up. So your blood glucose levels are high. That glucose doesn't go into the cells. So as far as the cells are concerned, they are starved. It's like, for example, you're sitting in the middle of an ocean and you're feeling thirsty. There's water everywhere, but you don't get anything to drink. Same way they're surrounded by glucose, but they are starved as far as they're concerned because the glucose is not entering inside the cell. So when the cells are starved, they signal the hypothalamus. So the hypothalamus thinks that the person is starved, so that makes them want to eat more, right? So you eat more, so that's why you have polyphagia. You're always there hungry. When you eat more, your blood glucose levels continue to rise. When blood glucose levels go up, this glucose is filtered through, like or most of the other molecules, it's filtered through the kidneys. Now, in the kidneys, there's a threshold for how much glucose can be filtered. So let's say if this is the optimum level in your bloodstream of glucose as a graph, if this is the optimal level, all of the glucose will be filtered and then it will be reabsorbed by the body because glucose is a nutrient which your body needs. So it's filtered by the kidney, and then in the kidney tubules, when we do the urinary system, you'll see the kidney kind of reabsorbs it back and sends it back to the bloodstream. But in the case of diabetes, your blood sugar level is this high. So what happens? This much is filtered and reabsorbed. This part which is filtered cannot be reabsorbed because it doesn't have enough proteins to reabsorb that. You have more than normal amount of glucose which can be reabsorbed. So that glucose goes out in the urine. Glucose is osmotically active. Remember I talked about sodium, how it was osmotically active. So glucose also is osmotically active. Since it passes in the urine, what it does is it drags water with it. So with the result, you pass more urine. That's the reason why you pass more urine. So you have polyuria. And this is also the reason why in a person you see sugar or glucose in the urine. So you have glucose in the urine because not all of the glucose which is filtered is reabsorbed. Since you have a lot more than normal being filtered, the body can only reabsorb so much. Your threshold is reached. The rest of it doesn't have enough carrier proteins to reabsorb it, so it passes it out in the urine. That is osmotically active, so it drags water with it and you have polyuria. Now you're passing so much urine, so naturally you get dehydrated, so you start feeling thirsty. So that's why you have polydipsia, or you have increased amount of thirst. So these are three main symptoms that you see in diabetes. Some of the other things that you see in diabetes is people have poor wound healing. You must have heard of it. People who are diabetic, they've been told even when they have to clip their nails, they have to be very careful. And, any small wound, they must take care of it because it shouldn't get infected. Our healing will be poor. One is infections are common because the blood is so rich in glucose and bacteria thrive on it. So, infections can are quite common. Second thing is this high blood glucose level. It tends to affect nerves and blood vessels. So it causes microvascular changes in the blood vessel. It causes changes in the nerves. So it ends up in affecting nerves and blood vessels. So when nerves are affected, sometimes a person may not even feel the sensation of pain or anything in that area. When blood vessels are affected, then blood flow to that area is impeded. So again, wound healing depends on having an adequate blood flow. So that is not happening. So again, these people have poor wound healing. In fact, this excess glucose can actually go and get deposited in the lens of the eye. So people with uncontrolled diabetes are very prone to cataracts too. And the high glucose affects, like I said, blood vessels. So they can be blood vessels in the kidney. So, you can end up with hypertension because the kidney is affected. It could affect the heart again. So, all these are kind of other symptoms which can occur with diabetes. So let's look at some features which we see with diabetes.
Finding out you have diabetes can be scary, but don't panic. People with diabetes can live long, healthy lives. Sure, let's go over some basics. This is diabetes. Made simple. When we eat, food travels to the stomach. Food is made up of 3 basic nutrients: carbohydrates, proteins, and fats. During digestion, carbohydrates are broken down into sugar, otherwise known as glucose. Here's a quick fact. Carbohydrates include foods such as bread, rice, pasta, potatoes, fruit, milk, and yogurt. In a normal digestive process, sugar travels from the stomach, through the bloodstream, to your body's muscle and fat cells. However, sugar can't enter these cells without the help of a special hormone called insulin, which is produced by the pancreas. Insulin acts like a key, unlocking the doors to the muscle and fat cells and allowing the sugar to enter. The cells then use this sugar as fuel to provide energy for the body. When this process is functioning properly, sugar entering the bloodstream from the stomach is able to exit the bloodstream at the muscle and fat cells. In this manner, the body is able to regulate the concentration of sugar in the bloodstream. Now let's see what happens in a person with diabetes. Sugar enters the bloodstream, but one of 2 things happens. Either the pancreas does not produce a sufficient quantity of insulin to match the sugar entering the bloodstream, or the body cells do not respond to the insulin that the body is producing. In both cases, the result is the same. Cell doors remain closed, causing sugar to get backed up in the bloodstream. As a result, blood sugar levels rise. This creates several problems. Because sugars are not able to enter your body's cells, your body is not getting the fuel it needs. As a result, you may feel tired or fatigued. Your body may try to dilute the excess sugar in the bloodstream by pulling fluid out of your cells. This can leave you feeling dehydrated and thirsty. Most importantly, over time, exposure to high blood sugar levels can cause damage to vital organs connected to the bloodstream, such as your eyes, kidneys, nerves, and heart. If not controlled properly, diabetes can lead to serious complications, such as blindness, amputation, kidney failure, heart attack, and stroke. In order to avoid these complications, people with diabetes must take steps to keep their blood sugar levels in a normal range. One way to do this is through diet. By reducing the amount of carbohydrates you eat in a single meal or snack, you can regulate the amount of sugar entering the bloodstream and prevent your body's insulin supply from becoming overwhelmed. This may mean limiting high-sugar foods such as cake, pie, candy, and soda. You know which ones. Another way to regulate blood sugar is through exercise. Physical activity makes your body's muscle and fat cells more receptive to insulin. In other words, those muscle and fat cells that wouldn't open before, now they will. Finally, your doctor may prescribe oral medications to increase your supply of insulin, regulate the amount of sugar entering the bloodstream, or make your body's cells more receptive to the insulin your body is producing. In some cases, insulin shots may also be necessary. Okay, let's review.
So this tells, so type 1 diabetics, do you think would they need insulin shots, or do you think they would need medication which will increase the production of insulin? They would need shots because their their beta cells are destroyed. So even if you give them something which increases the production of insulin, that's not going to help, right? They're not going to be able to produce insulin. Type 2 diabetics are the ones who diet and other things, and you give them something to increase the production of insulin. But quite often, if they are mismanaged and things sort of get worse, then they might have to rely on insulin also, because the body kind of gives up after some time. So let's look at this question. You would expect type 1 diabetic patients to be, which one of these would apply to them? Oh, very good. Yes. They do produce ketone bodies. Because they have to rely on fat and protein breakdown to produce ATP, so they are very, very thin, so they tend to break down the fat and protein to produce ATP. And because there's fat breakdown, that fat can get deposited in the arteries and cause atherosclerosis. So that's why they have all three of these. Let's look at the last gland, which is the pineal gland. It's part of the brain, of a region of the brain known as the diencephalon. It produces this hormone called melatonin. And the melatonin the function of melatonin is to make sure that your diurnal rhythm, or what is also known as circadian rhythm, which is the sleep-wake cycle, is kept constant and working. And they now think that it possibly has some antioxidant properties. And the thing with melatonin is more of it is produced during the dark periods. So whenever it is dark, that's when more melatonin is produced. So if you look at this, so let's look at this slide here. So let's say that it's dark. So there are fewer impulses from the retina, because the retina is not stimulated in the dark. So fewer impulses go to the hypothalamus. So the hypothalamus does not stimulate the sympathetic system as much. So the pineal gland is kind of not inhibited. So melatonin is secreted and it causes you to be sleepy. During daytime, because light falls on the retina, so more impulses from the retina go to the hypothalamus, which in turn stimulates the sympathetic nervous system. That produces epinephrine and norepinephrine. And that epinephrine and norepinephrine acts on the pineal gland and it inhibits melatonin secretion. So that's why you don't feel sleepy during the dark periods. That's why people who have difficulty sleeping, we always tell them that, make sure your room is absolutely dark. Do not turn on the light even if you have to go to the bathroom, because any little bit of light kind of will activate the sympathetic nervous system and melatonin secretion will decrease. This is also one of the reasons why you suffer from jet lag, because it kind of maintains your sleep-wake cycle. So when you travel, go from one area to the other, that cycle is kind of disturbed. And they say that it takes about, for any 1 hour difference in time, it takes 24 hours for the body to adjust. So that's why probably, I don't know whether that was the reason. That's why, whenever we have this, we kind of either turn our clocks forward or we turn them back. We do it on Sunday morning so that you have, because it's an hour before or an hour after, you have 24 hours to kind of adjust to it, So if you're kind of 8 days away, so 8 hours away, you can understand it's going to be more than a week before you kind of adjust to this whole time. So they say the best way to sort of deal with jet lag is to do what the local people do. So if they are going out during the daytime, you go out and get a lot of sunlight, so your melatonin secretion is depressed, then you won't feel as sleepy. So that helps to a certain extent. Some people suffer when they go from west to east. They tend to find jet lag a little bit more. Some people coming from east to west, and I think it's a very individual variation that happens. Okay, let's look at this question. Is the secretion of melatonin increased in winter or not? Yes, it is increased in winter because in winter the nights are much longer. The period of darkness is much longer. So that's why it's increased in winter. Okay, let's look at one more question. So this is kind of general, using all of the hormones that we've done. Which of these is not a hormone pair based on antagonistic action? Okay. Well, the correct answer is growth hormone and thyroxine. Okay. And here's why. Parathormone so this was the correct answer. So it's not a pair based on antagonistic action. So that was the question. Look at parathormone and calcitonin. They both act on calcium metabolism, right? Parathormone raises serum calcium. Calcitonin decreases serum calcium. Look at insulin and glucagon. They act on blood glucose. So the question was would not be considered a hormone pair. Insulin and glucose. Insulin raises blood glucose levels. Insulin decreases blood glucose levels. Glucagon raises blood glucose levels. So can you see they have an antagonistic action on glucose. These two have an antagonistic action on calcium. ADH and ANP. If you remember, ADH decreases urine formation. So less water is excreted through the body. ANP does exactly the opposite. Remember, atrial natriuretic peptide, it throws sodium out and it along with it water follows. So ANP is an antagonist to both ADH and aldosterone. So this increases water removal from the body. This decreases water removal. So again, they are both acting on water. So that's a hormone pair. Growth hormone and thyroxine, they don't have anything that they are antagonistic about. They both cause skeletal system development, muscular system development, both cause protein synthesis. So, they have the same action. So nothing that they're antagonistic about. Either one acts on thyroxine increases the basal metabolic rate. Growth hormone not necessarily affecting all cells, but it's not an antagonistic action. Okay. So that's why growth hormone and thyroxine is not one which is an antagonistic pair. Okay. I think that finishes this.